Hello, my friends. Today we're talking about pneumonia, and I'm using pneumonia as an exemplar of respiratory diseases. So all the questions are going to be about pneumonia, but I'm going to talk about respiratory treatments in general, as well as the exemplar of pneumonia. And we're going to talk about it as an infectious disease of the lower respiratory tract. So remember that nurses' role is to treat patients' responses to illness. It's not our only role, but one of our main roles is to treat a patient's response to illness. And there's only so many responses a patient can have in response to an infectious disease of the lower respiratory tract. And so I want you to think about pneumonia as a concept. Think of it conceptually, an infectious disease of the lower respiratory tract. What happens? What kind of patient's responses will they have? And then we'll ask some questions to make sure that you're able to think conceptually as you're answering pneumonia questions. So that's coming right up. Stay tuned. Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. I'm a part of the Greater Clinic Review organization. I run the YouTube channel, and we also have an NCLEX review that you can get on demand. Mark Klimek, the GOAT himself, teaches that on demand, streaming on demand. And we also have a streaming service where both Mark and I provide videos for that. And then we have our small group tutoring, which you can purchase in monthly slots. And so there's 4 small group tutorings each month, and you pay for 1 month and you'll get those 4 tutorings. One of them is with me, 2 of them was with Mark Klimek, and 1 of them is with Pete Savard. So today we're talking about pneumonia, and I'm going to talk about it as an infectious lower respiratory problem. So let's go ahead and start by talking about pneumonia and when you can know that it's a serious problem. So it's an infection of the lungs. Okay, so an infection. So most often it's bacterial, sometimes it's viral. We're going to talk about it as a bacterial infection. Most often it's community acquired. It can be hospital acquired, it can be ventilator acquired, that kind of thing. We're mostly going to talk about it as community acquired. And one of the ways we decide if somebody needs to be hospitalized for it is by looking at their CURB 65 score. Now, I don't think they're going to necessarily ask you about the CURB 65 score on the NCLEX, but it should give you an idea of when do you know the patient is unstable. So if they have to be admitted to the ICU, they're certainly unstable. And then if they have to be admitted for inpatient, they're heading in the direction of unstable. So I want you to think about this. So someone has an infection of the lungs, right? So someone has an infection, so you're going to expect them to be coughing. They may feel a little short of breath. They may have some dyspnea. You would not necessarily expect their oxygen saturation to fall. You would not necessarily expect their vital signs to be unstable. So their temp might go up and their respiratory rate might go up a little bit, but you don't expect their respiratory rate to be in the 30s. You don't expect their pH to start to change, right? Their ABGs to become abnormal. They're going to be fatigued because they're tired, or they're fatigued because they have an infection and their immune system is responding to that. So they're going to have the typical aches and pains. They're probably going to have a cough. If they're hydrated well enough, they'll have a productive cough. The productive cough may have some blood in it just because of the irritation to the lungs. It could be yellow-green because of the infection, right? So those are some of the typical things that you expect with pneumonia. And if you see those things, you say, well, we can give them an oral antibiotic and they can be treated outpatient. We'll do a chest x-ray. We see that they have this infection in one of the lobes. We give them oral antibiotics. They go home. We do a follow-up, make sure they're still doing okay. And then they're better, right? So there's many, many people who are treated for pneumonia outpatient. When do we have to admit them to the hospital? So here, if you look down here at the scores, 0 or 1, so look at mortality, right? It has a pretty low mortality, although 1.5% mortality, in my opinion, is still kind of high, but 1.5% mortality will treat them outpatient as a 0 or 1. If they go up to 2, they're almost at a 10% mortality rate. And so we're going to have to treat them inpatient. And then if it's 3 or greater, all of a sudden we have almost a 25% mortality rate. They're going to be admitted to the ICU. So what gives people points? Well, if they're confused, that gives them a point. And I will say that usually happens in older adults. You should, I hope, are familiar with the idea that older adults often manifest an infection First, by being confused. And so if an older adult suddenly becomes acutely confused, we take them in to get them worked up. Do they have a UTI? Do they have pneumonia? Do they have something else going on? They can get a point if their BUN goes up, because that usually means that they're dehydrated. Okay, so dehydration is what happens when their BUN goes up. If their respiratory rate goes above at 30 or above, I told you shouldn't expect their respiratory rate can go up. It may be in the low 20s, but you don't expect it to be 30 or above. That gives them a point. If their systolic blood pressure starts to drop, and that tells you they may be becoming septic, right? So the pneumonia, the infectious agent has gotten into the blood and they may be septic, or if they're 65 years or older. So just being 65 years or older gives them a point, okay? And so if they're confused and older, they're going to be hospitalized. If they're confused and older and they're dehydrated, that's a 3. They're going to end up in the ICU. So what I'm telling you is just think conceptually about these things, okay? And so that's what you're going to see. So their white count, we expect that, you notice it doesn't say anything about their white count. We expect their white count to go up. It doesn't say anything about their temperature. We expect their body temperature to go up. We expect them to have a fever. That's not unexpected. We expect them to have aches and pains. We expect them to have a cough. They can even have a purulent cough. None of these things are on the CURB 65 score, right? Because these are expected findings of a person with pneumonia. These on the CURB 65 score are all unexpected findings. And these are things that we have to treat immediately, that we have to be more aggressive with. Okay. So that's the reason I'm showing you that CURB 65 score. I do want to talk with you generally from a conceptual standpoint about respiratory interventions. So there are only so many respiratory interventions that we have. So they could have pneumonia, they could have TB, they could have COPD, they could have acute bronchitis, they could have a strep infection of the throat. This is lower respiratory infections, but even upper respiratory infections, y'all, there's only so many things we can do. So no matter what the problem is, these are the things we're going to do, y'all. We can position them. If they're short of breath or dyspneic, we can position them. If they're coughing or they have fluid in their lungs, we can do coughing and deep breathing. If they're hypoxic, we give them oxygen. If it's an inflammatory process, pneumonia, COPD, these are inflammatory processes, we can give them steroids. If it's an infectious disease like pneumonia or TB, we can give them antibiotics or antivirals. If it's asthma or they have bronchoconstriction as a result of the issues that they're having, like pneumonia, sometimes you can see bronchoconstriction, certainly asthma, you see it. We give bronchodilators. If they're having trouble coughing up what's in their lungs, we can give them an expectorant. If they're dehydrated, we give them IV solutions. If they have the flu or they have pneumonia, we can make sure they're vaccinated. Then for the people who become more unstable, we can give them respiratory support. So if the disease is causing them to become hypoxic or their respiratory rate is over 30, they're becoming fatigued, they're struggling to continue to breathe, we can give them respiratory support in the form of BiPAP or CPAP. Worst case scenario, they become so fatigued they can't maintain their saturations and their ABGs are going really off. We can put them on a ventilator. And then we can give them, if they have a fever or pain, general malaise, we can give them ibuprofen, we can give them acetaminophen and so forth. Okay, so y'all, there's only so many interventions. So don't pick some wacko off the wall intervention for a respiratory disorder. Just, that's not what we do. Okay. The only thing I forgot to put on here was PNPD, where we kind of pound on the back to try to loosen up the secretion. So we can do that. That would probably go with the cough and deep breathe. So there's only so many interventions that we have, y'all. So just make sure you think conceptually and say, what is this disease? Is this an infectious disease? If it's an infectious disease, I better give antibiotics. If they're dehydrated because they're sick, I better give fluids. If they're bronchoconstricted because of asthma or because of COPD, we can give bronchodilators. So how do you know they need a bronchodilator? If they're wheezing, how do we know that they need an antibiotic? Well, if they see fluid in the lungs and they tell you it's an infectious disease, if they tell you their BUN is elevated or their urine output is low and they tell you they're dehydrated, then we're going to have to hydrate them, right? So pay attention to what the question is telling you the problem is. I told you we're using pneumonia as an exemplar of an infectious lower respiratory disease. So if we think about an infectious lower respiratory disease, what are the interventions here that we would want to use with that? Well, depending on how they feel, we might want to do positioning. So if they're short of breath when they're laying flat, we're going to position them. Are we going to do coughing and deep breathing? Well, an infectious disease of the lungs, they have consolidation of fluid in their lungs, right? So we're going to do coughing and deep breathing because if they get put on the antibiotic and that consolidation starts to loosen up as the organism is killed off, they're going to need to cough that up. Will we use oxygen with pneumonia? That is going to depend if their O2 sat is under 93%. So if it's 92% or below, we're going to use oxygen. So don't just assume you're going to use oxygen with pneumonia, y'all. You've got to know their O2 sat. Certainly it's a problem with many of the people who are hospitalized, but make sure you have the data to support that. Do we use steroids with pneumonia? We often do. And that's just because for people who are quite ill from pneumonia, so if they end up in the hospital, we don't use them outpatient, okay? But if they end up in the hospital, a lot of times we will use steroids to decrease the inflammation just to kind of ease their breathing. But don't assume it, okay? Steroids are more standard of care with COPD. They're not as much standard of care with pneumonia. So I would not assume it. But if there's a reason to think they might need steroids, then we could do that. Antibiotics, absolutely. Antivirals, absolutely, depending on if it's a bacterial infection or a viral pneumonia. Bronchodilators, if they have wheezing. If they have wheezing, we can use a bronchodilator. Do we use cough expectorants with pneumonia? If they're having trouble coughing up what they've got, absolutely, we can use that. Do we hydrate them? If there's evidence for it, if they tell you they're dehydrated or they tell you the BUN is elevated, and an elevated BUN in the absence of like an elevated creatinine, because creatinine tells you it's kidneys, but if they only tell you the BUN, it's a hydration issue and we need to hydrate them. Vaccinations, there are pneumonia vaccinations that we can encourage them to get. Do they need respiratory support? Only if there's evidence for it, y'all. Only if there's evidence for it. How do we know someone needs respiratory support? Well, if their respiratory rate is over 30, they probably need some respiratory support, right? So if their respiratory rate is like 18, but their O2 sat is 92%, I'm probably just going to try some oxygen. Or if their respiratory rate is 24, but their O2 sat is 90%, I may just try some oxygen first. But if their respiratory rate's been in the 30s, their O2 sat, maybe they've got oxygen on at 4 liters and their respiratory rate is still in the 30s, even though their O2 sat is okay now, they're at 95%, 4 liters oxygen, but their respiratory rate's been high in the 30s for 12 hours, I'm going to be talking to somebody about getting some respiratory support because they're going to fatigue. That's going to exhaust them to breathe that fast for that long. When do they have to be intubated? They usually have to be, respiratory failure is intubation. How do we know when they're in respiratory failure? We know they're in respiratory failure when their ABGs show a CO2 in the 60s and or an O2 PaO2 in the 60s. So as the CO2 goes up, because normal CO2 is 35 to 45, so as CO2 goes up, their lungs are failing to get rid of the CO2. As their O2 goes down, the PaO2, as that goes down, that tells you they're failing to exchange gases. So if they're failing, what's the job of the lungs? The job of the lungs is to exchange CO2 and O2. That's the job of the lungs. If it's not exchanging those gases, that by definition is respiratory failure. So when do they need to be intubated? With respiratory failure. How do you know they're in respiratory failure? You have to have a set of ABGs and the CO2 has to be in the 60s and the PaO2 has to be in the 60s. So normal PaO2 is 80 to 100. Normal PaCO2 is 35 to 45. If you are unfamiliar with ABGs, you can watch my ABG video. I'll link to it in the comment section. Okay. Okay, so would we use fever pain reducers with pneumonia if they have a fever and they're uncomfortable? Sure. So how many of these interventions would we use with pneumonia? Positioning, cough and deep breathe, oxygen if needed, antibiotics for sure, bronchodilators if they have wheezing, cough expectorants most likely, hydration if their BUN is elevated, vaccinations, pneumonia vaccination we would recommend, BiPAP, if their respiratory rate is high and we can't get their respiratory rate down. Ventilator, if they're in respiratory failure. Fever, pain reducers, yes. All right, so if you just look at that and think conceptually. Y'all, don't memorize this list. Think of it conceptually. That's how you have to think of this. All right, let's do some questions. When reviewing the laboratory values for a client admitted with pneumonia, which result would cause the nurse to collaborate quickly with the healthcare provider? So what this means is, which one are you most concerned about? It's just a different way to say which one are you most concerned about. The white blood cell count of 14.5, PaO2 of 68, PaCO2 of 46, or blood glucose of 146. So blood glucose 146, I mean, that's high, but it may be high because of a stress response. So our stress hormones elevate blood sugar so that we have more energy to fight off the infection. So I'm not that concerned about D. It's not necessarily expected, but it's also not dangerous. The white count is basically a 14.5, right? So do you expect elevated white count with pneumonia? Absolutely. So that's expected. PaO2 of 68, that's unexpected, y'all. Remember I told you a PaO2 in the 60s could indicate respiratory failure. So that's unexpected. I'm concerned about that. PaCO2 is slightly elevated, but not much, and it's not in the 60s. It's not in the 60s. So the one I'm most concerned about, the totally unexpected finding, is the PaO2 of 68. A nurse is assessing a patient with suspected pneumonia. Which of the following assessment findings would the nurse be most concerned about? Another way to ask the same question. Okay, the same question. Last time it said, would you collaborate with the physician most quickly? What are you most concerned about? Same question. It's the unexpected finding. That's what you're always most concerned about. That's what you always have to address first. That's always, if there's an unexpected finding, that's always what you're going to call the doctor about or collaborate with the physician about. That's always what you're going to report to the next shift, is the unexpected finding. O2 sat of 92% on room air. That's unexpected, y'all. Most people with pneumonias, O2 sats don't drop. So 92% is low. It's unexpected. Crackles in the right upper lobe. Well, that's expected with pneumonia. That's exactly what you expect with pneumonia. Productive cough, expected with pneumonia. Dyspnea on exertion, that's expected. Dyspnea is a subjective finding, y'all. They say, I feel short of breath. So a subjective finding of dyspnea with exertion, not dyspnea at rest, but dyspnea with exertion, I'd go, well, you do have pneumonia. You might want to rest for a while we wait for those antibiotics to work, right? So the only one that I really am confident is unexpected is A. A patient is admitted with a diagnosis of community-acquired pneumonia. Which of the following symptoms should the nurse address immediately? Same question. I'm going to address the unexpected finding immediately. Unexpected finding doesn't mean I'm not going to treat the other things, but I don't have to immediately address it because they're expected with pneumonia. Fever and chills, that's expected with pneumonia. Pleuritic chest pain, that's actually expected. That's very common, especially when you have a lot of coughing or you have an infection. That pleural area can be irritated, and that's expected. Hemoptysis, coughing up blood, that's serious. Well, y'all, you've got an irritated lung. It's not unexpected to cough up blood. Now, if it says they're coughing up huge chunks of blood and big blood clots, I'm going to go, well, that's a problem. But don't read into this. Don't read into it. Hemoptysis, little blood in the sputum. Okay, that's expected. Bradycardia. What? That has nothing to do with pneumonia. I don't expect that with pneumonia. My dog is down here, so I'm petting him. I don't expect bradycardia with pneumonia. So that is the one that I have to address immediately. A patient with pneumonia presents with confusion and lethargy. Well, that's unexpected. Remember the CURB 65 score, confusion? What is the most likely pathophysiological explanation for these symptoms? Bacterial toxins affecting the brain. Ooh, that's pretty serious. I'm not quite sure I want to go there yet. That's wow. Okay. Only if nothing else makes sense. Okay. Dehydration due to fever. Dehydration is not necessarily causes confusion. That's not usually what causes it. So again, I'm thinking I'm crossing that off. Hypoxemia leading to decreased oxygen supply to the brain. That makes more sense. Okay, that makes more sense than bacterial toxins affecting the brain, or hypoxia leading to decreased oxygen supply. So if they have pneumonia and they're confused, they could be hypoxic. That makes sense. Hypercapnia, that's an elevated CO2, hypercapnia, from increased respiratory rate. Okay, y'all, hypercapnia does not result from increased respiratory rate. Think, y'all, you're blowing off CO2 when you have tachypnea like that. Increased respiratory rate is tachypnea. I don't expect hypercapnia from increased respiratory rate. I would expect a dropping CO2 from tachypnea. So the only one that not the only one, the one that makes the most sense and doesn't kind of go off the rails is C. Okay, that's the one that makes the most sense. A, is that possible? I mean, if they've gone septic and yikes, that's really going off the rails a little bit, y'all. The one that makes the most sense is C. Which patient with pneumonia would require hospitalization? So think CURB 65. Again, you don't have to memorize it. Just think conceptually, though. 25-year-old with a temperature of 101.5 and mild dyspnea. Well, those are expected findings with pneumonia. Okay, those are expected findings. A temp and some dyspnea. Okay, give them some antibiotics and treat them outpatient. They all have pneumonia, by the way, all of these. Okay, all these people. 40-year-old with a productive cough, that's expected, and type 2 diabetes. Okay, they have a comorbidity, but there's nothing there that tells me they have to be hospitalized. 65-year-old. Okay, 65-year-old is old enough to be hospitalized. That's 1 point with confusion and tachypnea. Well, confusion gives them 2 points. I don't know tachypnea. I don't know how fast it is. If it was over 30, they'd have to go to the ICU because that would be 3 points. But if it's under 30, they could be admitted to the hospital. But the age and the confusion gives them 2 points. They have to be admitted. A 30-year-old with pleuritic chest pain, that's expected, and 93% oxygen saturation in room air. Well, that's still within normal limits. It has to be 92%. Well, actually, the O2 sat isn't enough to admit them to the hospital. It's not enough. That's just one. That would be 1 point. And actually, O2 sat isn't even on the CURB 65 score. So that's a little bit less clear about the person with a D, although their 93% room air is fine. So the only person that really has to be hospitalized is C. A client is admitted to the medical surgical unit with a diagnosis of bacterial pneumonia and reports dyspnea, a productive cough, and fatigue. Which of the following intervention should the nurse implement first? Guaifenesin, antibiotic. B is antibiotic. C is positioning. D is essentially cough and deep breathe, Incentivespirometry. So we've got the typical interventions for respiratory interventions. We've got a expectorant in A, we've got an antibiotic in B, we've got positioning in C, and we've got cough and deep breathe in D. So how do we know which one to do? Because they all have to be done, right? They're all typical expected interventions for a patient with pneumonia. So what you have to do when you get a question with a diagnosis and symptoms in the question, you have to address the objective finding first. The objective finding. Objective is the physiological, over subjective. Subjective is treated after objective findings. So the diagnosis of bacterial pneumonia, that in and of itself is an objective finding. So they have a diagnosis of pneumonia. So that's objective. Dyspnea is subjective. I feel short of breath. Dyspnea is subjective. A productive cough, they report, and it says they report a productive cough. So I'm going to go with subjective because they're reporting it. And they report fatigue. These are all subjective findings. So it didn't say you observed the sputum or the mucus. If it had said you observed sputum or mucus, I would say that's objective. But they report dyspnea. I feel short of breath. I'm reporting a productive cough. Maybe they coughed it up and swallowed it. I don't know. A lot of people do that. Not saying it's nothing wrong with that. And fatigue. So these are subjective findings. So I have to address the bacterial pneumonia, the objective finding first. The guaifenesin is an expectorant. Well, they have a productive cough. I don't know that that's that important. The antibiotic is for the pneumonia in and of itself. Elevating the head of the bed, maybe that's for the dyspnea. Incentivespirometry, again, that's for the cough. The only one that's for the objective finding is the antibiotic. And you might say, well, I was taught to always give the antibiotic first. That's another thing to remember. Okay, that's another thing to remember. However, if it said that they had an O2 sat of 90%, I would apply oxygen before I'd start the antibiotic, y'all. I would. because ABCs, you have an objective ABC, objective airway, breathing, circulation, objective, not subjective. Dyspnea is subjective. So don't go, well, that's ABCs. No, 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 no. It's subjective. So if you have multiple objective symptoms, go with ABC first. Okay. Again, I have a number of prioritization videos that you can watch that will help you with that. So don't go, Sharon, I need more than that. Yep, I know you do. Watch my prioritization videos if you are struggling with this. A nurse is educating a patient about the use of an Incentivespirometer for pneumonia recovery. Which instructions should be included? Use the Incentivespirometer before going to sleep at night. Maybe. Exhale into the device as forcefully as possible. Exhale into the device. You don't blow into it. You're taking a deep breath, right? Incentivespirometer is to encourage deep breathing, not exhales. So you exhale, then you put it to your lips, go, and you inhale. That's how you do Incentivespirometer. So exhale or blow into the device? No. Inhale slowly and deeply to raise the indicator. That's true. That's what you do. You have to inhale, use the spirometer only when you feel short of breath. No, that's not true. So I know A and D are not my best answers. Y'all, if you have to, I don't care if the people sitting next to you think you look weird. Pretend to do Incentivespirometry. Otherwise, you're going to get this wrong because there's something about Incentivespirometry that you get confused. And people always want to blow into the Incentivespirometers. Have you ever noticed that? People pick them up and they start blowing into them. You're like, no, 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 no. You have to exhale first and then breathe in. You're doing deep breaths. Okay, that's what Incentivespirometry is about. During discharge planning, which statement by the patient indicates a need for further education about pneumonia management at home? Further education is a false statement. Looking for the false statement. I will finish the entire course of prescribed antibiotics. Good. That's good. I like that. I should increase my fluid intake to stay hydrated. Yes, that's true. You do want to stay hydrated. I need to limit my physical activity until fully recovered. I mean, yeah, they're sick. They've got pneumonia. I'm not going to tell them to go out and jog or walk around the block. I'm going to say, you can rest more until you're fully recovered. I can stop taking my medication if I feel better. Well, that's not true. They have to take the full course of the antibiotics. That requires further teaching. That's the false statement. A client arrives to the ED with suspected pneumonia. They have decreased breath sounds in the left lower lobe, a non-productive cough. Their oxygen saturation is 90% on room air, and they are confused to the date and time. What is the highest priority nursing intervention? Administer oxygen. Well, administering oxygen is for the O2 sat of 90%, which is an objective finding. So I like administer oxygen. Administer an expectorant. Expectorant is for the non-productive cough. Okay, so that's an objective. We'll assume the non-productive cough is an objective finding. So that's an objective finding. So fine, start a large bore IV. There's nothing specific there that's addressing. I'm not saying I wouldn't start a large bore IV, but there's no specific finding in the question that I'd start it for. So I'm going to not have that be my first thing. That starting a large bore IV is not going to be my first thing. And don't say, but I got to give the antibiotic. You do need to give the antibiotic. And I would start an IV, but it's not going to be first. I have an objective finding of O2 sat 90%. Okay. I have an objective finding that's pretty significant. Reorient them to date and time. Well, disorientation is an objective finding, but it's neuro. And I always want to do ABCs first. So if I'm going to, so I have objectively, I have a confused patient, I have a hypoxic patient, and I have a non-productive cough. I'm going to say I'm going to reorient them later, maybe 5 minutes later, but not first. Expectorant, they have a non-productive cough. You might go, well, that's airway. Y'all, not really. Not really. Okay. We've got an O2 sat of 90%. We have to administer oxygen first. That's what we have to do. A patient asks how to prevent pneumonia. Which of the following should the nurse include in the teaching? A patient asks how to prevent pneumonia. Okay. Prevent a pneumonia. Avoid going outside in the cold weather. Okay. Cold air is not what causes pneumonia, y'all. Maybe there are some people that think that, but that's not what causes pneumonia. So no. Get the pneumococcal vaccine as recommended. Well, that's supposed to prevent pneumonia. Okay. Yeah. Avoid dairy products to reduce mucus production. No, that's not how we avoid pneumonia. Take antibiotics whenever you have a sore throat. No. If you have a sore throat that's not bacterial, you're not going to take antibiotics. You only take antibiotics when you have a bacterial pharyngitis. Pharyngitis is sore throat. You only take antibiotics when you have a bacterial pharyngitis. So no, I'm not going to take it whenever I have a sore throat. So the only one that prevents pneumonia is the vaccine. Well, I hope that was helpful to y'all. I have some other respiratory videos. I think I have a COPD video. I have an ABG video. I can put the links to those in the comments below. And I hope you have a great rest of your day. Good luck on your NCLEX, y'all. Thanks for being part of the Clinic Review family. And I'll see you later.